Hello guys, I am Shalika welcoming you to the show Pharmacy and Medical Crash Course Division in the Knowledge Club online. At previous episode, we learned about renin-angiotensin blocker drugs for heart failure. Today, we will learn about rest of the part of drugs for heart attack and failure. Not wasting the time of giving the invaluable lectures, know more about the drugs for heart failure. Stay tuned up to end because if you skip the lecture, you can miss our valuable points in between lecture. So stay tuned up to end. I am going to start today's episode. Let's start. First drug is the Digitalis. In 1875, William Withering wrote a treatise on Digitalis. In the period between 1875 and today, 2020, the popularity of Digitalis has undergone many ups and downs. In chronic CHF with chronic atrial fibrillation is its still an extremely favored drug. The cardiac glycosides are often called Digitalis or Digitalis glycosides because most of the drugs come from the Digitalis means foxglove plant. They are a group of chemically similar compounds that can increase the contractility of the heart muscle and therefore are widely used in treating heart failure. We discussed at Antiarrhythmic chapter the cardiac glycoside influence the sodium and calcium ion flows in the cardiac muscle. There were interesting contraction of the atrial and ventricular myocardium, the positive inotropic action. The Digitalis glycosides show only a small difference between a therapeutically effective dose and doses that are toxic or even fatal. Therefore, the drugs have a low therapeutic index, the most widely used agent in digoxin. The sources of drugs, the Digitalis purpura, digitoxin and gitalin, Digitalis lanata, digitoxin, digoxin, Digitalis gratus, wobin, Digitalis combe, strophanthin K. Advantages. It has positive inotropic and negative chronographic effect. It can be administered orally. And the drawbacks are the low margin of safety, correct use, correct dose, therapeutic ranges cannot be certain. It has many drug interactions. Mechanism of action. The regulation of cytosolic calcium concentration. The free cytosolic calcium concentrations at the end of contraction must be lowered for cardiac muscle to relax. The sodium-calcium exchanger plays an important role in this process by extruding calcium from the myocyte in exchange for sodium. The concentration gradient for both ions is a major determinant of the net movement of ions. By inhibiting the ability of the myocyte to actively pump sodium from the cell, cardiac glycosides decrease the sodium concentration gradient and consequently the ability of the sodium-calcium exchanger to move calcium out of the cell. Further, the higher cellular sodium is exchanged by extracellular calcium by the sodium-calcium exchanger, increasing intracellular calcium. Because more calcium is retained intracellularly, a small but physiologically important increase occurs in the free calcium ions that is available at the next concentration cycle of the cardiac muscle. It follows that if the sodium-potassium adenosine triphosphate is extensively inhibited, the ionic gradient becomes so disturbed that dysarrhythmias can occur. In the case of increased contractility of the cardiac muscle, The administration of Digitalis glycosides increases the force of cardiac contraction, causing the cardiac output to more closely resemble that of the normal heart. Increased myocardial contraction leads to a decrease in end diastolic volume, thus increasing the efficiency of contraction, increased ejection fraction. The resulting improved circulation leads to reduced sympathetic activity, which then reduces peripheral resistance. Together, these effects cause a reduction in heart rate. Vagal tone is also enhanced, so the heart rate decreases and myocardial oxygen demand diminishes. Memorize it. In the normal heart, the positive inotropic effect of Digitalis is counteracted by compensatory autonomous reflexes. Therapeutic uses. Digoxin therapy is indicated in patients with severe left ventricular systolic dysfunction after initiation of SCE inhibitor and diuretic therapy. Digoxin is not indicated in patients with diastolic or right-sided HF. Digoxin's major indications is HF with atrial fibrillation. Dobutamine, another inotropic agent, can be given intravenously in the hospital. But at present, no effective oral inotropic agents exist other than digoxin. Patients with mild to moderate HF will often respond to treatment with SCE inhibitors and diuretics, and they do not require digoxin. Pharmacokinetics. Digoxin is used clinically. T-half of digoxin is 1.5 days, while for digitoxin is 5 days. Presuming same dose is repeated at proper interval. To reach steady state, 4 doses are required. Thus, digitization with digoxin requires 4 into 1.5 is equals to 6 days, while with digitoxin is required 4 into 5 is equals to 20 days. Thus, this is a major trouble with digitoxin. Dialysis is of no help in Digitalis intoxication because after absorption, Digitalis is distributed mainly within the cells. Indications of the drug. In CHF with chronic atrial fibrillation, in CHF with sinus rhythm. Contraindications. Obstructive cardiac myopathy, diastolic dysfunction of heart, WPW syndrome, AV nodal block. Adverse effects. Digitalis toxicities are often grouped as cardiac, extracardiac as stated below. The cardiac dysarrhythmias are like delayed AV conduction, PSVT, heart block, ventricular tachycardia and ventricular fibrillation. Extracardiac means GIT, nausea, vomiting, anorexia, CNS, headache, blurring of vision, mental confusion. Predisposing factors for adversity. Some factors facilitate the development of Digitalis toxicity. Depletion of serum potassium level can occur if concomitantly used with furosemide or thiazides. Concomitant use of drugs like quinidine, presence of renal failure and hypothyroidism, old ages. Factors predisposing to Digitalis toxicity. The electrolytic disturbances. Hypokalemia can precipitate serious arrhythmia. Reduction of serum potassium levels is most frequently observed in patients receiving thiazide or loop diuretics, and this usually can be prevented by use of a potassium-sparing diuretic or supplementation with potassium chloride. Hypercalcemia and hypomagnesemia also predispose to Digitalis toxicity. Drugs. Quinidine, verapamil and amiodarone, to name a few, can cause digoxin intoxication, both by displacing digoxin from tissue protein binding sites and by competing with digoxin for renal excretion. As a consequence, digoxin plasma levels may increase by 70 to 100%, requiring doses reduction. Potassium depleting diuretics, corticosteroids and a variety of other drugs can also increase digoxin toxicity. Hypothyroidism, hypoxia, renal failure and myocarditis are also predisposing factors to digoxin toxicity. Second type of drug, that is beta-adrenergic agonist. Beta-adrenergic stimulation improves cardiac performance by causing positive inotropic effects and vasodilation. Dobutamine is the most commonly used inotropic agent other than Digitalis. Dobutamine leads to an increase in intracellular cyclic adenosine monophosphate (CAMP), which results in the activation of protein kinase. Slow calcium channels are one important site of phosphorylation by protein kinase. When phosphorylated, the entry of calcium ion into the myocardial cells increases, thus enhancing contraction. Dobutamine must be given by intravenous infusion and is primarily used in the treatment of acute HF in a hospital setting. Administration of either milrinone or amiodarone increases CAMP levels by preventing its degradation by cardiac myocyte phosphodiesterase. Both classes of CAMP elevating agents have been shown to be helpful for the acute short-term management of the decompensated patient. Unfortunately, the long-term continuous use of either of these classes of agents in the outpatient setting has been associated with an increase in mortality in CHF. However, the use of these drugs appropriately selected patients is highly effective for symptomatic relief. Third drug, that is diuretic. One cannot discuss the management of heart failure without including comments about the kidney. The relationship between the heart and the kidney makes intuitive sense when one considers the importance of the kidney in maintaining an appropriate volume status throughout the body. An analog that may be useful to consider is the situation in which an individual turns on the faucet at the home to find that little water is flowing. The first assumption is that a leak somewhere in the system is responsible for the lower water pressure. An appropriate response is to turn off the water to the house. In an analogous manner, the kidney perceives low cardiac output from a failing heart as a leak. The kidney begins to elaborate hormones designed to retain fluid. Many of the problems in CHF result from an inappropriate neurohormonal activation by the kidney in response to perceived volume depletion from hemorrhage. Mechanisms that result in vasoconstriction are normally compensatory in the short term for acute bleeding. These same adaptive mechanisms become damaging in chronic heart failure. The usefulness of diuretics in the management of CHF cannot be overstated. Before diuretics were available, rotating tourniquets were used to diminish venous return by ligating the lower extremities. Less venous blood returned to the right side of the heart and pooled in the legs. This procedure diminished the effective intravascular volume that accumulated in the lungs. The availability of loop diuretics, particularly furosemide, has resulted in the ventricular virtual elimination of this practice. Loop diuretics. Loop diuretics such as furosemide block the sodium-potassium chloride symporter in the ascending limb of the loop of Henle. The resultant effect is delivery of more sodium to the distal tubule and enhanced urinary loss of sodium and water. Unfortunately, the resultant increase in urinary excretion of hydrogen and potassium can lead to arrhythmias. The potential for arrhythmias is exacerbated by the loss of magnesium and calcium ion and an underlying vulnerability of the myocardium in CHF. However, loop diuretics are still part of the mainstay of therapy for CHF despite these potential problems and the absence of well-controlled multicenter clinical trials. The rationale for their use is so compelling that placebo-controlled studies appear unethical. Moreover, Furosemide was accepted as the standard of care in all of the clinical trials that form the basis of recommended therapy for CHF. The use of potassium-sparing diuretic spironolactone has been shown to improve survival. The spironolactone is the only diuretic that has been shown in a double-blinded, multicellular prospective clinical trials to improve survival in CHF. That is also a aldosterone antagonist drugs. The addition of spironolactone to Digitalis and an angiotensin-converting enzyme SEE inhibitor significantly improves survival among patients with chronic severe heart failure. This study has conducted with patients who were not taking a beta adrenal receptor blocking agent. It is unclear at present whenever the addition of spironolactone to a combination of Digitalis, SE inhibitor and a beta blocker will also confer additional benefit. Spironolactone competitively inhibit the binding of aldosterone to cytosolic mineralocorticoid receptors in the epithelial cells in the left distal tubule and connecting duct of the kidney. Aldosterone enhances salt and water retention at the expense of enhanced renal K+ and H+ excretion. Spironolactone enhances diuresis blood blocking, sodium and water retention while retaining potassium. An obvious potential side effect in hyperkalemia, which is aggravated by the potassium retaining properties of the SCE inhibitor. The likely concomitant use of the loop diuretic furosemide, which depletes potassium, dictates careful monitoring of serum potassium to avoid life-threatening rhythm disturbances. There is also evidence for the existence of mineralocorticoid receptors on cardiac myocytes. This raises the intriguing possibility that spironolactone could mediate important direct effects on the myocardium in CHF. Fifth drug is the hydrolazine and nitrates. A major advance in the pharmacological management of CHF has been the demonstration that after load reduction improved survival. The concept of after-load reduction was developed for the treatment of mitral regurgitation. It was noted that a decrease in systemic vascular resistance as reflected in lower atrial blood pressure resulted in an increase in the percentage of blood that flowed from the left ventricle to the aorta as opposed to the left atrium, that is, decreased regurgitation fraction. The decrease in backup of blood into the lungs provided considerable sympathetic relief from dyspnea, fatigue, and chest pain. It was reasoned that patients with CHF often also have mitral regurgitation and might similarly benefit from more forward, that is, left ventricle to aorta, as opposed to backward, the left ventricle to left atrium blood flow. A cohort study in which vasodilator were added to Digitalis and furosemide was the first to demonstrate a significant improvement in survival in CHF. Patients were given either prazosin as a beta adrenoceptor blocking agent or the combination of the direct vasodilator hydrazine and a nitric oxide mediated vasodilator, that is, one of the nitrates. There were fewer deaths among the patients on the combination of hydrolazine and nitrates. Patients taking prazosin did not benefit, probably because chronic therapy with prazosin results in tachyphylaxis. Sixth drug, beta adrenoceptor blocking drugs. We studied in details about beta blockers at anti-arrhythmic drugs chapter. For many years, the prevailing view was the beta blockers are contraindicated in CHF. The physiological rationale for not using beta blockers in heart failure was certainly well founded. Heart failure patients have a decrease in cardiac output. Since cardiac output is a function of stroke volume times heart rate, that is, the CO is equals to CV into HR. An increased heart rate could be necessary to maintain an adequate cardiac output in the presence of the relatively fixed disease in stroke volume observed in CHF. A rapid increase in heart rate does play an important role in the physiological response to acute hemorrhage. Thus, a decrease in heart rate along with a depression in contractility produced by beta blockers would be expected to precipitate catastrophic decompensation that is certainly can happen in the acute setting. Several subsequent studies have led to the incorporation of beta blocker therapy using their carvedal or metoprolol into the standard of care on CHF. Patients already taking the Digitalis, furosemide and an SAA inhibitor were prescribed a beta blocker in these studies. Surprisingly, the long-term use of beta blockers in CHF improved ventricular function and prolonged survival. The assumption that an increased heart rate is necessary to maintain an adequate cardiac output in the case of a reduced stroke volume is clearly not true in CHF. The benefits of the use of beta blockage appear to exceed by far the risk of bronchospasm in patients diagnosed with chronic obstructive pulmonary disease, that is COPD, and or suppression of hypoglycemic responses in diabetes. COPD is very different from bronchoplasty asthma. Young people with asthma have highly reactive airways and can die within hours of a bronchospasm in response to an exposure to an external agent. This highly reversible dynamic condition contrasts sharply with the destruction of connective tissue in lung, parenchyma and dead airway sacs that are not very reactive. This is a very defined phenomenon. Beta blockers are adrenoceptor antagonists that bind to the beta receptor at the same site as do endogenous beta adrenergic agonists, such as norepinephrine. The norepinephrine binds to the adrenergic receptor which activates a G protein, which participates in the conversion of ATP to CAMP via adenylyl cyclase. CAMP activates protein kinase A or pKa to phosphorylate proteins such as the sarcolemmal L-type calcium channel that subsequently increase calcium, decrease heart rate, conduction and contraction. The beta blockers bind to the same receptor as does norepinephrine but do not facilitate G protein coupling. Occupation of the binding site by the beta blocker prevents norepinephrine from binding to it and stimulating CAMP formation. Circulating plasma norepinephrine levels correlate inversely with survival in CHF. That is, high level of norepinephrine are associated with a decrease in survival. It appears that norepinephrine levels are more than just marker of disease severity. Norepinephrine is actually directly toxic to cardiac myocyte, at least in culture. The addition of either an alpha or beta blocker confers partial protection from norepinephrine damage. Combined alpha and beta blockage confers additive protection. These data from animal studies may be relevant to human heart failure since they suggest that both alpha and beta adrenoceptor blockage may be beneficial in the management of CHF. This rationale favors the use of the combined non-selective alpha and beta blocker carvedal over the relatively selective beta-1 antagonist metoprolol. In addition, in CHF, the number of beta-1 receptors decreases while the number of beta-2 receptor increases and the ratio of beta-1 to beta-2 receptors changes. Thus, the beta-1 selectivity of metoprolol may not confer any advantage over the less specific beta blocker carvedal. It is clear from clinical trial data that beta adrenoceptor blockers are not all the same. Use of some has produced improvements in survival and others have produced no improvement at all. The mechanisms responsible for these benefits are not yet established. Speculation includes upregulation of beta adrenoceptors, improved G protein coupling, altered regulation of nitric oxide, and so on. Then, what's the order of therapy for heart failure? Experts have classified HF for 4 stages from least severe to most severe. Memorize it that as the disease progresses, polytherapy is initiated. In patients with overt heart failure, loop diuretics are often introduced first for relief of signs or symptoms of volume overload, such as dyspnea and peripheral edema. SE inhibitors, or if not tolerated, ARBs are added after the optimization of diuretic therapy. Gradually titrate the doses to that which is maximally tolerated and or produced optimal cardiac output. Beta blockers are initiated after the patient is suitable or stable on SE inhibitors, again beginning at low doses with titration to optimal levels. Digoxin is initiated in patients who continue to have symptoms of heart failure despite the multiple drug therapy. For example, treatment with digoxin plus a diuretic plus an SE inhibitor in patients with HF is superior to treatment with diuretics alone or a diuretic plus either digoxin or an SE inhibitors. So we completed today the chapter of drugs for heart failure. Today's lecture up to this. Next episode we will discuss on antihypertensive drugs. Revise the all episodes on heart thoroughly and made it step by step accordingly. Here the all previous episodes list on heart anatomy and physiology chapter and cardiac pharmacology chapter, and also the antiarrhythmic drugs for the pharmacology chapter, which can be helpful for these episodes. You will get all links at the discussion part of this video, or you can visit our channel. Before ending today's episode, if you like this video, please like, share and comment freely. Don't forget to subscribe our channel. If you already subscribed, then thanks a lot. And after subscribing our channel, please click on the bell button for getting the regular updates of Knowledge Club Online. I am coming with the another episodes very shortly for you. Till then, goodbye.